Um, as you heard, I am a medical oncologist in Singapore. I've been there about 10 or 11 years now. Prior to that, I was in Canada and have worked in other places. So hopefully I can share sort of some of my perspectives of things that I've seen around the world. So I think the first thing that I think is really important to always remember is that early treatment of triple negative breast cancer really is the best chance that patients have, because we know that it's the acute leukemia of breast cancer. So it's our best and one chance, because once patients relapse, we know that historically these patients live about 9 to 12 months with immunotherapy and other new targeted therapies, maybe up to 2 years, but we're not getting sort of the 4 or 5 year survivals that we're seeing with our ER positive and HER2 positive breast cancers. And so it really is on us to give the best treatment we think we can provide in the curative setting. And so I wanted to talk a little bit the guidelines. Some of them apply to us in Asia and some of them don't. And I think that's why ESMO has created the Pan-Asian adapted guidelines, which many of you on this meeting today have been participating on. And I think has been very enlightening to see some of the global differences. And I think, people have become a little bit more sensitive to it. So, the ASCO guidelines recommend that anybody who has at least T1C or greater should be offered an anthracycline taxane containing regimen, or at least what we'll call a third generation regimen. But I think, as many have you shown, and we know that in Asia, this represents a very small fraction of the patients that we see. And the ESMO guidelines suggest a sequential anthracycline taxane regimen, and in selected lower risk patients, a non-anthracycline or CMF could be used. And then for patients that have cardiac complications, a non-anthracycline regimen, which I'll talk a little bit more about. No, an area of great controversy is whether to include anthracyclines. And I think in the HER2 positive space, people have gradually become more comfortable at really eliminating anthracyclines because of such effective HER2 targeted agents. But in triple negative, we know that the risk of relapse continues to be quite high. And so people really feel strongly that they want to give their best chemo. And so, as we know, this was the ABC trials and looked at taxane anthracycline versus taxane alone. And this was data presented by Joel Bloom a few years ago that showed that in the node positive patients, there seemed to be absolute benefits, 10% or more in triple negative. So at least in Singapore, we still will include anthracyclines in the curative intent of when we're treating patients with preoperative therapy. Now, just listening to some of the other talks, when I arrived in Singapore about 10 or 11 years ago, only about 10 to 14% of our patients were getting preoperative therapy. And I think it's hard because patients really just want to get it out. They're afraid of chemo. They don't want the delay. But I think we've learned there are several advantages, especially in triple negative, of giving neoadjuvant therapy. And that's, beyond shrinking the tumor. It's many things, even patients adhering to therapy, being to escalate, de-escalate, potentially doing a different type of surgery, giving us time to do BRCA testing. So let's go through them, because I think they're important to reinforce. So the first thing is, if you're able to, it allows time to get genetic testing and related impacts. So decide if patients want to have a bilateral mastectomy for prophylaxis. And we know that up to 20% of patients harbor BRCA mutations, which is much lower in our non-triple negative colleagues. We can actually assess the response and provide a better estimate of prognosis, and possibly escalate therapy in the residual disease setting. And as we know, there are a number of potential options now for that. Now, it's a bit controversial, but do we get better outcomes by having earlier introduction of systemic therapy? Certainly, if you have a high-grade tumor, we know that the earlier you get therapy, the more likely you're going to start getting benefit. And finally, without a doubt, better chances of breast conservation. And even if you don't have breast conservation, improve surgical outcomes, reduce morbidity after surgery. So one of the things that I get asked is there a minimum size to offer preoperative therapy in TNBC? And again, I think in Asia, where the median stage of diagnosis is a little bit larger, we don't have to face this question as much as our colleagues in the West. But the ASCO guidelines suggest that if you have a T1A or T1B, these patients should not routinely be offered neoadjuvant therapy outside of a trial. ESMO guidelines for almost every subtype, actually, they say over 2 centimeters. My feeling is that the disease should be measurable. You need to be able to feel it and to monitor it. So that's generally my sort of feeling. Or if it's an older patient, or maybe it's a grade 2 tumor where it might be a slightly different histology. So that gets to this concept of the fact that we know for several reasons that triple negative breast cancer is very heterogeneous. One in terms of if you just look at it molecularly, but we don't have the technology now to test that in clinic or have it impact clinical practice. But I think one thing that does potentially affect clinical practice is some of these different histologies. And what I mean by that is, if you're an apocrine adenocystic low-grade breast cancer with a good prognosis, I think sometimes we're more keen to get those patients to surgery and really get a true state of their full pathology. But if you have a high grade, ductal carcinoma, lobular, pleomorphic, those are the patients that have the poorest prognosis and really should try to get started on treatment as soon as possible. And then what's interesting is most recently there was some data in the JAMA network this year that looked at a few of these rare histologies. Now, these represent less than 1% of triple negatives, but nonetheless, what it shows you is that these different subtypes of TNBC have very different natural histories. So I think you don't have to see the data to know that the metaplastic patients have the worst prognosis, are very hard to treat cancers, and that that's where a lot of the focus has to be, and collaborative efforts are underway. But the adenocystics and the medullary. So this is just to highlight, these are stage 1. So even a stage 1 metaplastic, 50% of those patients unfortunately have relapsed within the first 3 years of diagnosis. Stage 2, as you can see, still those same patterns exist. So if we're giving more and more neoadjuvant therapy, really the most important thing is looking at the pathological complete response. So after we give their neoadjuvant therapy, what's left? And really what we're hoping for, and what our patients know that we're hoping for, is no residual invasive disease in the breast and the axilla. So I think many of you are familiar with this meta-analysis that Laura Spring presented and published, is looking at this large meta-analysis, individual patient-level meta-analysis of almost 30,000 patients. And so again, we always have to be reminded that if you're triple negative and you get a PASS-CR rate, over 90% of those patients have long-term disease-free survival. Whereas even within the first 2 to 3 years, if you have residual disease, there's a very high chance, that you will relapse in those first couple of years. So there's your massive differences. And so that's where a big focus on research is. But it's also why we want to give neoadjuvant therapy, because if you have residual disease, these are the patients that we have to target our therapy. And I think a lot of people are familiar with the most recent trial looking at CAPE versus Carbo, where, they had patients, only 44, 48% of those patients were disease-free. Now, how do we improve that PASS-CR? So that's really been the goal, is how can we augment the PCR? And so one of the thoughts was, we know that triple negative breast cancer in general harbors some BRCA-ness, so features that are shared with germline BRCA, or might be susceptible to drugs that interfere with DNA damage. But what we've also learned is that platinum may have its effect through immune-mediated apoptosis, just as many other chemotherapies have. And so I think this has really been a great interest for really over 10 to 15 years as we try to improve outcomes for triple negative. So two of the studies that have been quoted for years are the GEPAR-6 and the CLGB trial, both slightly smaller studies, but looked at platinum versus in addition to standard chemotherapy. Now the GEPAR-6 was a slightly unusual chemo in that it had liposomal dox and bevacizumab. Nonetheless, though, both of these trials showed an improvement in PASS-CR that now pushed beyond 50%. These GEPAR-6 trial saw this translate into a 10% improvement in EFS, but the CLGB trial really saw a non-statistical improvement in EFS. And so why this is so important is that up until recently, the guidelines were actually quite inconsistent. So the NCCN guidelines in 2019 had suggested that they don't recommend carboplatin, but in fact, in the last year now, it says you can consider it. The ESMO guidelines around that same time said that you can consider it for triple negative or patient with germline BRCA. Now, all of this changes just a couple of weeks ago, in my mind anyway, from the Brightness study. So the Brightness study was a fairly large phase 3 study that looked at standard anthracycline taxane chemo plus platinum plus veliparib, which, as we know, is a slightly less potent PARP inhibitor. And they looked at PASS-CR as the primary endpoint, and secondary endpoints were event-free survival. And this is presented by Sybil Leubel. So we'd seen data a few years ago showing that more than 20% improvement in PASS-CR with the addition of carboplatin. And for many people, this was a game changer. So, some of our colleagues in the UK that had been a little bit reluctant, I think the Brightness trial was much more convincing. It was a larger study. And so from this time of the Brightness data in 2018, I think we saw gradually an increase in platinum. But what we were most excited about was hearing just 2 weeks ago now, was the sub-stratified analysis of event-free survival looking at the addition of platinum. And what you can see here, the blue line of the patients that just got anthracycline taxane, and the maroon and green are the patients that got the addition of platinum. And you can see there is 10% or more improvement in event-free survival. So in here, you can see the paclitaxel, anthracycline, 68.5. When you add platinum, it either goes to 78 or 79. So really more than 10% improvement in EFS. Now, what about toxicities? Well, as you know, one of the arms was veliparib, but they still looked at, were there any increases in MDS or secondary malignancies, and there was no difference between all of these groups. And the other question that's been really difficult to tease out is, is it just the germline breaker or is it just the wild type? And what you can see here is that regardless of BRCA status, there seem to be improvements in PASS-CR. Now, you can see the numbers are much smaller in the germline BRCA, but it's quite amazing how early, and look at the hazard ratio, 0.14. So really, I think for many people, this solidifies that, in the germline BRCA patients, that the addition of platinum provides advantage in addition to an anthracycline cyclophosphamide taxane regimen. Now, why this is important is that, as we know, there was a recent trial looking at residual disease of platinum versus CAPE, but that was in the residual disease setting. This is looking at the upfront strategy in combination with our standard chemos. So their conclusions were that these findings support the inclusion of carbo and neoadjuvant therapy for stage 2-3 triple negative, irrespective of BRCA status. Now, many key people are keen to give a non-anthracycline combination, and Priyanka Sharma has been spearheading this approach. And here she did a fairly small but important study called the Neostop trial. And there she looked at carbotaxel AC versus carbodocetaxel. So basically 8 weeks versus 6 weeks of chemo. She did not give primary prophylaxis of note, so there was a slightly higher rate of toxicity in terms of myelosuppression in the carbotaxel. Now, I should note that these were fairly lower risk patients, so stage 1 to 3, but nonetheless, they saw identical PASS-CR rates. They also looked at RCB, which again was very similar, and similar event-free survival. So we're looking forward to seeing potentially a larger study looking at an anthracycline sparing combination. But for now, in my practice anyway, I'm reserving this for patients who have contraindications to anthracyclines. Now, I think we're all quite keen to figure out, well, does everybody need platinum? We keep adding drugs. And I think we all know that not all patients need platinum, just like not all patients need anthracyclines. And ironically, we've had chemotherapy for decades, but we don't have good assays being able to identify chemo responsiveness. So in fact, just a few days ago in Annals of Oncology, this is work from the GBG group, they're looking at the association of RAD51. And you can see here, RAD51 did seem to predict for more benefit from platinum versus the RAD low with the HRD assays. But as you know, none of these are yet ready for clinical practice, but we hope that we can see with these large data sets, they can guide us further. Now, this was almost a year ago that Hope Rug and I did this debate on, should we be giving platinum to triple negative? And we had to come up with a title because I said, should be considered. And they wanted to do all. And I said, we can never say all. So we agreed on the title of most. And so I think given the brightness title, I think this does sort of, for me, again, have everything come full circle, that we should consider it for most stage 2-3 neoadjuvant therapy patients. But remember, don't compromise on your taxane dosing. I think the data from especially the CLGB study showed that if you didn't sort of optimize your dose of taxanes, the patient did have higher relapse rates. So again, considering your high risk. So just shifting for a moment to immune checkpoint inhibition, we know that, or we've always hypothesized that immune checkpoint inhibition might work earlier. And why is that so? Well, we know from our metastatic data that the later you treat with immunotherapy, the less likely it is to work. And that's partly due to immune escape. And so the later lines therapy, single agent combination doesn't seem to work as well. Whereas you go in the earlier line setting, when you biopsy those tumors and you compare them to the advanced tumors, you're seeing higher rates of stromal TILs, higher rates of interferon-related gene expression, and multiple other signatures that are actually showing us benefit from immune checkpoint inhibition. So it's not surprising that we've seen better results or impressive results in the early breast cancer setting. Now, I don't have a lot of time to go into it today, but I did want to sort of highlight how we really have made some progress. So these are two large randomized phase 3. There are many other sort of smaller phase 2s, but I just wanted to focus on these two phase 3. Both of them were looking at standard anthracycline taxane chemotherapies with the addition of immune checkpoint inhibition. And both of these large phase 3 studies showed improvements of about 15% in terms of pathological complete response. And you can see there with Keynote 522, we're getting at pass CR rates of 65%. And we all know how important that pass CR is. More recently, we presented, or Peter Schmidt presented, the data from Keynote 522, which included patients from around the world, where they showed an improvement in 8% in terms of event-free survival at 3 years. And we know that 3-year mark is really important. And so to have these patients, so 50% of them were node positive. These weren't sort of low-risk patients. These were high-risk patients, and 10% improvement over the years in terms of event-free survival. So almost 85% event-free survival at 3 years for these patients is very impressive. Hazard ratio of 0.63, and you can see that this has recently been approved by the FDA. And the EFS data for Impassion 031 is not yet mature. Now, one thing that's really important to mention is that in the metastatic setting, we use PD-L1 positivity as our sort of biomarker to select patients, but in the early breast cancer setting, you do not need to select. It seems that all patients, and even more so perhaps PD-L1 negative patients, benefit. So until we have more data, there's no way to select the patients. Now, I want to thank Lisa Carey for this slide, because I think it highlights, the Gepard Nuevo, which I think is, really impressive, because it also showed randomized phase 2, showed overall survival data, but was not a phase 3 trial. But across all of these 3 studies, we saw improvements in outcomes. And what's important to me, though, is that these PD-L1 patients clearly do better. So you can see here, 70%. Having passed CR versus only 48 to 45. So those PD-L1 positive patients are the lucky ones, because they have higher pass CR rates regardless, but they also seem to derive benefit from immune checkpoint inhibition. So these PD-L1 negative patients certainly derive a lot of benefit from immune checkpoint inhibition, but overall they don't do as well. So how to manage residual disease with my last few minutes. So just reminding you that this, in terms of looking at outcomes, was in patients receiving pre-op chemo. We don't know if this paradigm holds true for immunotherapy. But certainly we do know patients have residual disease. For many of us, the standard has been giving capecitabine for residual disease, and that's really because of the survival benefit we observed in the CREATE-X trial. We now have another option. As we know, the Olympia trial was given both in the adjuvant setting, but also in the residual disease setting. And in patients who are germline BRCA had residual disease, you can see there was improvement in event-free survival or invasive disease-free survival. And I think what's amazing is that the curves here is 77 to 86%. And I think we were all quite reassured that we didn't see these secondary malignancies. Now we're going to have to wait longer, but certainly the hazard ratio of 0.58 got us very excited, and certainly this is now included in the ASCO guidelines. But for many of us, costs will be quite prohibitive. And so I think very much so, we hope that the companies, certainly AZ, will work with us to provide help with genetic counseling, but also improve the sort of cost effectiveness of these new compounds. So systemic therapy in 2021 for triple negative. So neoadjuvant timing is a must for all, but the smallest node negative, to allow us to de-escalate the surgery, allow us to risk stratify for treatment of residual disease. If capecitabine is all we have, it's a good drug. We've had it for many years. It's not expensive. Anthracycline taxane regimens are the standard. Now, I saw previously in one of the previous patients, some people are still using TAC. In Canada, we sometimes use TAC, but many of us have moved to a sort of sequential regimen. I like to give it as per Keynote 522 with the taxane platinum first, followed by the anthracycline. Our colleagues at MD Anderson many years ago highlighted some preclinical data about overcoming resistance. So I'm in favor of doing the taxane platinum first, very much as was seen in brightness, but I'm not giving 6 cycles of an anthracycline, so we don't use TAC. We do use capecitabine for residual disease, and now, as we know, IO is approved for Keynote 522, and de-escalation is on the horizon. Now, what we don't know, and we know that we don't know how to choose the right patients for immunotherapy. Certainly, all of our patients can afford it. It is associated with rare but significant toxicities. We don't know the duration, so patients with a PCR, should we continue? What's the sequencing? And how do we do if we have a patient with CAPE, IO, PARP? And I think we're going to need biomarkers, we're going to need other studies to guide us. So the last question are, what are the chemo gaps? So I think we all agree that pre-op chemo for greater than 2 centimeters, but what about those patients, 1 to 1.9? And we have a lot of trouble debating, I think, if it's measurable, but sometimes I do take these patients to surgery. And as I said, in Asia, this doesn't happen as much. The majority of our patients, as I saw in the previous presentations, are larger tumors. Who can be spared chemo? Well, all but the very small ones, I still give chemo. I think it's your one chance that you can treat it, unless it's truly a grade 1 with a very low Ki-67, potentially with one of those favorable histologies. And then chemotherapy for our lower risk tumors. We don't have data, but I think a non-anthracycline is likely sufficient for these lower risk tumors. Whether you're giving TC with the cyclo or TC with carbo, I think both of those are reasonable regimens. So I want to finish with a very sort of optimistic tone. This was a paper just came out a few days ago. And I think why I thought it was so important is that, even though we can't do this in the clinic yet, what they clearly showed is that we have this inflamed, ignored, excluded TNBC, and they looked at these spatial immunophenotypes. Now, it's going to be years before we use this in clinical practice, but I think it shows us that the future will be a pathway. It won't be simply a biomarker. And as technologies become less expensive, just like BRCA status is, we may have a way of making all of this quite cost effective. So not having to give immunotherapy to everybody, but figuring out who really needs it. So 20 years of progress in dissecting triple negative breast cancer. Little by little, we're getting there. But 5-year, 85% event-free survival is something we just didn't used to see. So with that, I want to acknowledge many people have shared slides with me, and thank you for your attention, and look forward to the panel later on. Thank you very much.